Morning, everybody. Dr. Gillard here once again, and for the last time this week. This is the end of week 5 for me. This is the final Thursday lecture for cardiovascular and pulmonary pathology, CVPP. And I hope everybody's doing well out there and staying safe. As I stall for time to get my little marker up. Okay, here we go. All right, we left off, we talked about aneurysms quite a bit, dissecting aneurysms, but here's a different kind of vascular phenomenon called an arteriovenous fistula, AV fistula, commonly known as an AV fistula, arteriovenous fistula. It's an abnormal communication between an artery and an adjacent vein. Now, for this to occur, they have to be really close. We saw in anatomy how arteries, especially medium-sized ones and smaller arteries, they tend to run side by side. In fact, we saw many examples of how satellite veins kind of chaperoned the artery in the middle, right? These are the ones that are amenable to this phenomenon of arteriovenous fistula, where this is the artery in the middle, two satellite veins. Okay, so a fistula, by definition, it just means a communication between two pipes, new communication. This is not an arteriovenous shunt. An AV shunt is a normal occurrence in capillary beds or just upstream from capillary beds. But the problem is if we get a shunt in between an artery and a vein where it's not supposed to be, it can siphon off all the good oxygen and nutrient-rich blood, and it can shunt it into the return system, into the venous system. And therefore, downstream capillaries get cheated out of nutrients, oxygen, things like that, and it can cause ischemia and kill the tissue. So that's not a good thing. Here's just to jog your memory, an AV anastomosis. So the blood flow would be this direction. Here. Right? Could be this direction. Back to the heart this way. So if here's just a cartoon, maybe there's more capillary beds up here further that these pipes go to. But if we want to shut down these capillaries, which we often do, we talked about medarterials, how we can shut them off here. But that's not the only way we can shut them off. We can also open up these tubes, and these are called arteriovenous anastomoses. And it can grab the blood, right? And it can kind of shunt that blood, even though you lose oxygen. It doesn't matter, especially if you're having trouble blood volume. You can open those up. So that's what an AV shunt is, or AV anastomosis is another AKA for that. But these are not what we're talking about. We're talking about abnormal communications. There's an normal AV shunt here. But here is two adjacent venules, or an arterial running. There's a capillary bed down there. It's going to feed. And here is what an anastomosis, AV fistula looks like. A fistula is a communication, abnormal communication between two tubes. And that's exactly, there it is normal, and there it is not. Notice what happens to the vein. What's happening to the vein? It's bulging out. Why is it bulging out like that? Well, how much pressure is a vein, and especially a venule, how much is it designed to handle? It doesn't have a thick. Look at its skinny little tunica media right here. Right? Compared to this thick tunica media. And that's muscular. Venules are muscular. Yeah, it's not made to take that pressure. So the pressure causes a varicose vein. It stretches this out, just like in any varicose vein formation. Okay, so that's an AV fistula. What are the causes? It's usually some kind of inflammatory condition where you've got a vasculitis or you've got an infection. that's gotten into the tissue or the bloodstream, and that the infection damages the wall between the artery and vein, and it breaks it to the point, or it weakens it to the point the arterial pressure can just punch a hole through it. And then you got yourself AV fistula. Another really common way are bullet wounds and knife wounds, or even needle punctures. That's, have to be a pretty big needle for that one. Should probably take that out. It could be. I'll leave it in there. But yeah, if you double punch them and it heals because of the high arterial pressure, it won't let healing occur. And you'll have a abnormal communication. Sometimes they're made on purpose for dialysis. I used to talk about that, but there's the YouTube link. You can watch it if you want. They can be congenital, especially ones in your brain you can be born with, but that's not the norm. It's usually something more of an acquired type condition. Where do they occur? They can occur anywhere where arteries and veins run side by side. So these are not going to occur usually in the aorta and big vessels like that. They're usually in the smaller vessels. You can actually add smaller vessels. Just make a note here. So the brain can be really dangerous. We'll look at those. They have a special name, AV malformations, which is a type of AV fistula. But yeah, it can occur in the lungs anywhere where they run side by side. What's the sequelae? Downstream ischemia. Just talked about that. So I don't think I have to elaborate on that anymore. They also can cause some congestion. If the tissue's not getting enough blood downstream, the body's going to sense that and try to fix that problem by pumping harder. The heart will pump more blood and work harder to fix that problem. So you can wear out the left heart. I'm doing this during this process. And it could be a cause of chronic hypertension. Some primary hypertension, they don't know what the cause is. They do the usual tests for renin levels, aldosterone levels, and things like that, and they give up. But maybe it's an AV fistula in the brain, or called AV malformation. So it could be a cause of chronic hypertension. Varicosities, several varicosities may also form, as we showed you an example, because of the high pressure. Talked about that. The varicosities could rupture. We're talking about sequelae of these things. A rupture could occur, and you could bleed. And if it happens in the noodle, that's a really bad thing, right? Especially if it's a subarachnoid hemorrhage. We talked about how that blood causes a release of endothelin, and it causes all the other blood vessels to go in a vasoconstriction, and it could kill you. It causes a massive stroke. Here's just a cartoon of some familiar vessels. We know the ulnar artery and the cephalic vein, and these have come in fairly close contact in this, the way this is set up. And I'm not so sure this, probably the interosseous would be closer contact, but just to make the point, here's an anastomosis that has occurred here. No, actually, I guess this can. But yeah, so the vein is all stretched out, and how would the modified Allen's test? It would be, or the Allen's test for that matter. It wouldn't be that good because a lot of the arterial blood is kind of dumped out, so you don't have good blood flow going down to the ulnar artery. Okay, also another sequelae. Where's all that? If you get all the extra blood coming into the right side of the heart, how's that going to react to that? It's not. This blood's designed to be kind of used down here, and it's not supposed to be blasted back into the right side of the heart. That can damage the lung microcirculation and cause scarring. Then the right heart has to start pumping harder to push blood through the lungs, and you get a failure of the right heart and pulmonary hypertension. So that's another problem. Look at this guy. So this is, I think, in India, but he ended up having a cephalic vein AV fistula, secondary to an AV fistula running between one of the arteries and the cephalic vein, and just over the years, the pressure has just completely destroyed the cephalic vein. Right? And then so this is ugly, but that in and of itself won't kill him, but all that blood dumping into the right heart, he was having trouble with dyspnea on exertion. And so he's ruined his heart. He's ruined the right side of his heart. He's ruined the lungs, scarred up the lungs, and he's got pulmonary hypertension, right ventricular hypertrophy. Why? Because he didn't take care of this when it was little. At one time, you could just barely see it. And if he would have fixed it then, he wouldn't have ruined his heart. And now he's kind of SOL. Okay, another type of AV fistula in the brain is called an AV malformation. It's the most common type of AV fistula. These can be really dangerous if they're up in the noodle, and they're a little different than a run-of-the-mill AV fistula. They're more like a tangled knot of arteries, veins, venules, arterioles, and fistulas, many fistulas between them. So it's really a tangled knot. Here's a great picture of a AV malformation, which is considered a class of AV fistula. These only occur in the brain and spinal cord, greatly increase the chance of stroke if they rupture. In fact, 2% of all strokes going through the ER end up being an AV malformation was the cause of the stroke. Can also be on top of the spinal cord. And let's see, yeah. So this is a 64-year-old with bilateral leg pain, a positive Babinski sign, hyperreflexia, positive Romberg sign, all signs of myelopathy, right? Not this time, not because of central stenosis pushing the back of the spinal cord, but we have this big extramedullary AV malformation that was the cause of this thing. Neurosurgeons got to come in and clean that thing up. What's the prevalence? It's rare, but it's twice as common as Marfan syndrome. It's 0.01% of the population. Typically, the problem will show up in 2/3 of the patients before the age of 40. 4% of them hemorrhage. If it hemorrhages, it does carry a risk of stroke. 17% of the hemorrhages stroke out. Neurological sequelae, about 1/3 of them. 10% of them die from this, so this is not a good thing. I actually know 2 students since my 5.5 years I've been with Palmer. I've known 2 family members of students who have had loved ones die from this. So it definitely is out there. Symptoms usually completely asymptomatic until the ischemia starts kicking in. It's usually patient dies and it's discovered on autopsy, or maybe they have imaging of the brain, they have headaches or something, and they discover it there. Again, the symptoms, about 12% of them experience ischemic symptoms, and those can be widespread. We got ischemia of the brain, it's not a good thing, so they might have a seizure. They could have paresis or paralysis or palsy of a cranial nerve, loss of coordination, headaches, severe headaches, memory problems, hallucinations, speech difficulties, dizziness, kind of the usual suspects up there. Here's just another cartoon of blood, how it's cheated through these things. And if this is a piece of brain tissue, it's not getting enough blood because all the blood is running through this tangled knot of arteries and veins. All right. Change gears. Let's talk about atherosclerosis. I debated about every quarter. I debate about taking these out because I think you've had a lot of this stuff, but then I always have students say, "Don't take it out," because we haven't had enough of it. So here it is: atherosclerosis, pronounced atherosclerosis. Carlton, which is a nice, he's a good storyteller. Maybe not quite deep enough, but it's a good clinical pathology book. There's no other disease in the Western world that inflicts so much morbidity and mortality than atherosclerosis. And it is a problem. It's clogging of the pipes, right? Here's a a pipe that came out of somebody's house, that might as well just be an artery. The abdominal aorta is the number one spot for this to occur, and it doesn't quite look like that, but it does look similar. We'll see a butterflied abdominal aorta. I think I've showed you one. Showed you the atherosclerotic plaquing. But it's not only atherosclerosis. It is all three types of arterial sclerosis. Remember, arterial, there's no L in here, arterial sclerosis. It's like arteriosclerosis. You didn't pick up the grocery sclerosis. Arteriosclerosis. This is the parent category. And underneath it, there's three subdivisions. There's three types of arteriosclerosis. Monkberg's is the one that calcifies the tunica media. We can see that on X-ray. Then we have arteriolosclerosis. The number one cause of hypertension is the presence of arteriolosclerosis, right? And then, of course, atherosclerosis, this one right up here. That's the third member. This is the one that, for whatever reason, the public talks about all the time, but pathologists are just as worried about arteriolosclerosis because that clogs up the arterioles, and that's where you control blood pressure. So people can have quite high blood pressure from that disease. Usually when a person gets atherosclerosis, there's a mixture. In reality, it's probably best to say arteriosclerosis because there's usually a mix of the other three. But you probably remember that from histology. And I won't go into the histology, the onion skin. Remember the onion skin appearance of... I won't get into all that, but hopefully they've went into that. It is a big problem, though. Major contributor to some really common diseases. Coronary artery disease. Cerebrovascular disease. Uh-oh, I got a cough. I'm going to try to turn off the microphone. Keep our fingers crossed. Did that work? I guess we'll come back to slide, where are we, 93, and see if that worked, because that would be handy. It didn't freak out Camtasia, so that's cool. All right, so major contributors to coronary artery disease. It loves to clog up the coronary arteries. That's a kind of a exception to the rule. Atherosclerosis likes the big pipes, but it likes the special pipes. These are medium-sized vessels, coronary artery and cerebral vessels, anterior, middle, posterior cerebral arteries, but they're special. They're designed a little bit differently. We didn't get into those, but they do, because of their special design, they are a target for atherosclerosis as well. PAD is caused by atherosclerosis. We already talked about PAD. Remember, that is atherosclerosis, sclerotic plaquing, usually of the abdominal aorta, maybe the common iliacs, maybe the external iliac, maybe the femoral. Usually doesn't make it to the popliteal. It is the underlying contributing factor in about 50% of deaths in the Western world. It's a killer. It's a slow killer, though. The likelihood of developing atherosclerosis depends on a combination of inherited genetic risk factors and acquired risk factors. Let's look at some of these acquired risk factors. That looks delicious, doesn't it? So, big fat hamburger covered with cheddar cheese, a bacon on top of that. That's not a bun, that's a donut. So that's a donut bacon cheeseburger. Looks fantastic. If you have problems with atherosclerosis, I mean, you could still eat one of those every now and then. You shouldn't be eating those every day. You're asking for early death if you do that. But those are things, these acquired risk factors are things we can control, like dietary cholesterol levels, too much red meat, and too much animal fat. Smoking is just as bad, if not worse. And then hypertension. Why hypertension? Because it causes atherosclerosis, as we'll see. There's inherited congenital problems or risk factors. I know some vegetarians who have hypertension, and they have atherosclerosis, bad atherosclerosis. Why? LDL receptor mutations, right? If you don't have LDL receptors, you can't pull LDL and cholesterol inside of your cell where it can be dealt with properly. If it runs wild, if LDLs run wild, there's an increased chance it can get between endothelial cells and cause trouble. There's some common target zones of atherosclerosis. Can get up in the noodle, as we said, the cerebral arteries. It likes the carotid artery as well. Can cause bruise. We've learned to check for that. Coronary artery it likes. It loves the renal arteries and the abdominal aorta and the iliac arteries. Kind of know that. What is it? It's an inflammatory disease, so it is considered an inflammatory disease. It loves the large, medium-sized, kind of big, medium arteries, especially the aorta, the iliac vessels, femoral, popliteals maybe, but it likes those special arteries, as I said, the coronary arteries, the cerebral arteries, the carotid arteries. It likes the renal arteries. Probably the worst possible targets for these things. What's the classic sequelae of end-phase atherosclerosis? PAD, we've talked about peripheral artery disease. Patient usually starts developing, he can't go for his walk, or she can't go for her walk anymore because her legs start cramping up and not working and hurting. And then pretty soon that happens just walking around the house, they start getting claudication. Then pretty soon they have claudication pain all the time. Right? And it can get so bad where you end up having to amputate your feet because of this. If it clogs up the coronary arteries, you can start getting angina going up the stairs at work. And nothing's done about that. It can lead to a full-blown myocardial infarction. Same with the noodle. It can start clogging up the cerebral arteries or even the carotid arteries. That causes ischemia to the brain, and you start getting TIAs, like mini strokes. And if you don't pay attention, you get a full-blown stroke, and then life might not be very good for you. If it clogs up the renal arteries, secondary hypertension, right? It turns on the R2A system. I think we're experts at that R2A system. We better be, because we got a test next week, right? Fun facts, does not affect the smaller arteries. How come it doesn't affect the smaller arteries? It's all about pressure. There's not enough pressure. We need higher pressure to break, kind of loosen up the endothelial cells so LDLs can sneak in between them. Same reason it doesn't affect lymph vessels or veins. Not enough pressure to break the endothelial cells apart. You got to get an LDL underneath the endothelial cells of the blood vessel to cause atherosclerosis. Usually develops, if it does become symptomatic, it's insidious, takes 20, 30, 40 years before you start showing signs. By the time signs are, you're in big trouble though. What clogs up the pipes? Atherosclerotic plaques. We'll look at that mechanism here in a second. But atheromas, you should know these AKAs for atherosclerotic plaquing, which is the end phase of atherosclerosis, the process of atherosclerosis. Atheromas, atheromatous plaques, or just plaques they're called, they're all the end phase of the inflammatory process of atherosclerosis. Even in patients 20 years of age or so, they can start developing these plaques. They can show up in young people, sometimes even younger. They've been seen in kids sometimes. But the thing is, just because you have them, it doesn't mean that it's going to turn into a plaque. Just because you start having these fatty yellow streaks, which you can see. But they can. People who are going down the wrong road, the plaques will be present in the 20s. Here's a cartoon. We'll talk more about this, but basically there's a blood vessel, and for whatever reason, we have breaks in the endothelium, and LDLs, these little yellow dudes, they've gotten in here, become oxidized, and a wicked inflammation process occurs with some really weird stuff going on. And this inflammation gets bigger and bigger. Foam cells, macrophage monocytes come in, turn into macrophage, and like Pac-Man, they eat all these little yellow things, and they get big and fat. And so fat that as they accumulate, they cause a beaver dam here of the blood vessel. Blood's going that way. And so now we got a beaver dam, and we even got a hematoma starting right here, or a big chunk of thrombus. I mean, that can break loose and cause an embolism. A kind of a plaque embolism can occur. That's where we're going. But yeah, they cause downstream ischemia. Everything I just said can happen. And obvious hypertension, right? The heart's got to pump harder to get through, especially if this plaque goes on for a long ways. The heart's got to do everything it can to service that tissue downstream from there. And it will do everything it can, but it has to work harder, and you can wear your heart out like that. Here's a butterflied abdominal aorta, and you can see it's just filled with gunk. That's all atherosclerotic plaque. There's probably some Monkbergs mixed in there with that as well. Is there arteriolosclerosis in here? No. Is that an arterial? No. That's down in the microcirculation. 4 ways plaque creates disease. I kind of talked about this, but it causes a beaver dam. It causes arterial luminal narrowing, which results in a beaver dam. Downstream ischemia, and causes hypertension because the heart has to push harder and pump harder, so the rest of the body has increased blood pressure, but the limb that it's affected maybe won't have, but it has normal pressure. If it happens in the renal arteries, you get R2A-induced hypertension. Could suddenly completely occlude a vessel. We'll talk about breaching here in a minute, which is a heart attack. That most heart attacks occurs after breaching of an atherosclerotic plaque occurs in the carotid or in the coronary artery. Right? So it causes a myocardial infarction. It happens up in the noodle, causes a stroke. Erosion, weakening of the vessel wall can occur as well. Maybe the beaver dam wears out the wall so much that it bulges out and causes an aneurysm. The aneurysm could rip and cause a rupture and a massive hemorrhage, and you could go into hypovolemic shock from that. The aneurysm could do damage as well. Maybe it doesn't rupture or bleed, but maybe it compresses a nerve that's nearby. Maybe it compresses a lymph vessel, which causes lymphedema. Maybe it compresses an artery next to it and causes downstream ischemia of that artery. So it can be pesky. Just the kind of the beaver dam or the bulging can cause beaver dams and other things, and compress other things. Excuse me. Okay. Arterial thrombus formation can occur as well. So that's usually with breaching, but it also, as it starts to breach, the endothelial cells get upset and they stop secreting the slippery 3, prostacyclin tissue plasminogen activator, known as TPA. And thrombomodulin, it stops secreting those as these epithelial cells in the inflammation zone, they stop working. And that encourages the thrombosis process. Von Willebrand factor can be oversecreted. Yeah, so we have arthrosis involved epithelial cells. They don't secrete. Then you can get increase for thrombus formation, and then maybe the thrombus breaks loose and you get a deadly arterial embolism. Okay, let's look at this. This is probably Dr. Doe's. Let me know if you think that I really need to keep doing this. I always ask this question. I always say, yes, we need this. Keep doing it. But let me know if that's still true. Really Dr. Doe's territory. But response to injury theory. Now, this is the number one theory, how atherosclerotic plaques develop. There are other theories, but this is by far the most popular. It's in Robbins, so this is board stuff. So it starts, as I kind of said, when LDLs build up in the bloodstream, either from eating that bacon hamburger with sandwich between two donuts. But the LDLs get in between the blood vessels and they get underneath into the lamina propria, and an inflammation occurs. That's the problem. The inflammation actually releases cytokines, which causes endothelial cells to shrink. That allows even more of these LDLs to sneak through once the sides of them shrink in. So endothelial cell damage most commonly occurs from chronic hypertension, right? And then as the beaver dam occurs, the hypertension gets worse and causes a wider area of sneaking LDL cells, and it expands the atherosclerotic process. Right? The hypertension beats up the tight junctions. I won't get into them again. We've talked about those. And yeah, the LDLs aren't supposed to sneak in. So let's look at a picture. So here's a dude with increased blood pressure. He's got hypertension. And finally, the tight junctions broke. And the LDL cells were able to sneak underneath here. And the remember there's blood vessels in the lamina propria region now? There's blood vessels in here, little tiny ones. And plus you got blood diffusing in here. So this is spotted by the immune system. And some factors are released, and these giant monocytes go right in here after them, because these guys are going to eat them up. Mutated LDL receptors, so you don't always have to have hypertension. If there's just too many of these guys around, maybe you don't have LDL receptors, you got thousands, maybe millions of these LDLs floating around. And so just by chance, they could get in health between two. Maybe they had a histamine reaction and these shrunk and it left a gap. So if you have too much LDL around, or if you're constantly eating hamburgers, cheeseburgers with bacon, all it takes is one LDL molecule to get in there, and you can start the process. Okay, what happens next? Once beneath the LDL cells, once beneath the endothelial layer, they become oxidized, and that oxidation attracts monocytes. A little more to it than that. There's some chemicals released, but those big monocytes come, and they also sneak between the endothelial cells. They kind of follow right where it came in, and they get a name change, right? When a monocyte enters a tissue, it becomes a macrophage. So macrophage are the first guys in, and here's an example of macrophages lining up to start taking care of these foreign invaders. All right, so macrophages, they come in and they eat the oxidized LDLs. They literally gobble them down like Pac-Men do. And they gobble, 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 and they start eating, and they get fat. They get so stuffed with these little oxidized LDLs that they become huge. And once the macrophage eats enough and becomes huge, it's called a foam cell. That's important. A foam cell used to be a monocyte. Monocyte turned into a macrophage. The macrophage overate. It becomes a foam cell. And there's so many of them that it starts to cause a beaver dam. It starts to push into the lumen. And you can start to see, if you stick an endoscope down the blood vessel, you can start to see these bumps, these beaver dams, these long columns of fatty streaks, they're called. What are they? They're just hundreds of thousands of macrophage overstuffed, called foam cells. Okay, that's the story with that. So another really weird thing happens with these smooth muscle cells. We think of smooth muscle cells as just contracting and causing vasoconstriction, vasodilation, but something weird, really weird happens. So the foam cells release certain cytokines. They call in more troops. The cytokines also make the cells shrink. So unfortunately, more LDLs can get in. So the inflammation gets worse. But the smooth muscle cells all of a sudden completely morph into something new. They grow little pseudopodia, little legs, and they can crawl out of the tunica media into the battle zone, and they become phagocytic. That's the craziest thing ever, right? How a smooth muscle cell becomes phagocytic. But that's exactly what happens. Here's some smooth muscle cells. You can see them all kind of hanging out here, responsible for vasodilation, vasoconstriction, but some of them have morphed into little moving creatures, look like little amoebas, and they leave the tunica media and they go into the battle zone. Here's the lumen of the blood vessels right here, and there's the epithelial layer, still epithelial cells, but they go in here and they start gobbling up these LDLs, these oxidized LDLs as well. So they contribute, and they start pushing this out further. So the beaver dam starts getting worse. The luminal stenosis starts getting worse. Okay, smooth muscle cells, then they decide, this beaver dam could break, and we don't want that to happen because they know immediate hematoma will form, or immediate thrombosis will form if it ruptures. That's called breaching. So they try to wall off the inflammation, and that's what they do. They swim. These guys have swimmed up here, and underneath the endothelial layer, they build a wall to prevent this from breaching, because you don't want this breaching. I mean, that can kill you, especially if it happens in the brain or in the heart. So that's another weird thing that they do. So not only did they become phagocytic, they can actually smartly wall off or try to wall off this inflammatory process and stop more LDLs from getting in. Doesn't always work, though. Here's just a really busy fatty streak here, the beaver dam. Everything we've just talked about, maybe in a little more detail. But yeah, we got most of it. Breaching is bad news. So if the plaque breaks open, what does that mean, breaks open? If it rips, if you erase these guys right here and blood is now gushing down into this, that's really bad. Von Willebrand factor, all sorts of procoagulant molecules, the blood will be exposed to that, and it will instantly clot, and you get a gigantic thrombus formation. Some call it blood clot because, this part would be the blood clot because it's outside of the lumen. This would be thrombosis. But you get a huge blood clot so big that it will completely plug up a coronary artery or a cerebral artery in the brain. All right, that's called breaching. So everything I said can completely occlude the artery and cause a stroke if it happens in the noodle, or a myocardial infarction if it happens in the heart. So not a good thing. And if that doesn't kill you, if we go back to this, if this doesn't kill you, and we got blood flowing this way, a big chunk of this could break loose, and if you're up in the noodle, and it could go into smaller arteries of the brain and get stuck and cause a stroke, cause death of tissue downstream. Okay, I think we're good there. Breaching. Here's another cartoon of what breaching has occurred. The blood, it would have to be a rip in here somewhere. And the blood has gotten into this and then trying to get out. But once the blood is exposed to all these prothrombogenic molecules, it will clot incredibly quick. All right, how are we doing on SIFE? Again, forgot to keep track of my time. I don't even know what time we started. Let's see, we started on 30. Oh, we got a little bit more work to do, so let's keep going here. Good, our ice. I just got a text. Sorry about that. Our refrigerator, our main refrigerator is down. We just lost a ton of food. Wife is freaked out. So we'll call the refrigerator repair guy again. Worst timing in the world. Anyway, blood pressure. So you remember these guidelines in 2017, the American College of Cardiology and American Heart Association together wanted to change the blood pressure guidelines, much to your dismay. But I got some good news. So right now, officially, according to these associations, now there's an elevated stage 1 and a stage 2 hypertension. The good news is that your board books, that's what you care about, right? Because you cannot write a board question. I can't write a board question that has not come from one of those list of board books. So Robbins, 2 pathology book, Bates, other books, they only recognize stage 2 hypertension as, quote, hypertension. They don't talk about it. You don't have hypertension until you hit stage 2 hypertension. So far, 2020 here, they haven't changed anything. So for boards, I wouldn't have to worry about memorizing all this stuff. But for sure, know that hypertension is defined as anything between 140 or at 140 to 180 and between 90 and 120. Those are your hypertension numbers. If you get over or at, if you hit 100, so if you hit 140, you have stage 2 hypertension. You have, quote, hypertension. If you hit 180, you actually have malignant hypertension. That's a medical emergency. They go right to the ER. That'll kill them if that's not taken down or make them blind. That pressure that high will damage organs. On the diastolic side, once they hit 90, they have hypertension. If they hit 120, they have malignant hypertension. That's all you have to remember for me. All this other stuff, in my personal opinion, I think this is just too much. I think it's going to lead to put people on hypertensive medications too early, rather than, they should be aware of it if they're starting to creep up around stage 1 hypertension. I think it's ridiculous, in my opinion. A blood pressure between 120 and 129 is now a pathology that's elevated. You're going to have some cardiologists putting people on medications at these levels, and it's ridiculous, right? They have their own sequelae. So I'm not happy about that. I personally get worried if the pressure gets 90 or above, diastole gets 90 or above. When it gets up close to 140, then I would start getting worried about things. Start considering medications, right? But until that time occurs, I would personally, because we can't prescribe medications and things like that, right? Chiropractors, but I was not happy when this came out. Anyway, so blood pressure, one of the most variable yet best regulated systems in the body because the tissue is so finicky. The capillaries have to have that tissue gradient that we talked about way back on day 1, and the body will do anything to ensure that occurs. So that normal capillary hydrostatic pressure gradient, it's extremely important. It has to be just right to drive nutrients out in the proximal capillary and be able to return waste products and excess interstitial fluid in the distal capillary. So it'll do everything it can. Elevated blood pressure is called hypertension. I hope we know that. It's definitely related to premature death and disability. It's a major risk factor for the development of atherosclerosis. The higher your blood pressure, the more cracks will occur in between endothelial cells, and that increases the chances that those mischievous LDL molecules will get in there and start an inflammation. It also increases the risk for contracting the SARS-CoV-2 virus, right? We know that as a strong risk factor. If you have hypertension, you have to be really careful. about that. There's something about the receptors it can bind to. Even if you are controlling that hypertension with blood pressure medication, you're still at risk. If you naturally have hypertension, you're at risk for getting SARS-CoV-2, which of course causes the disease called COVID-19. What's hypotension? So authors are all over the place, but the best Robbins and the board books say anything under 90 or anything under 60 is hypotension. And there's some of you listening who have blood pressure. One of those numbers is lower than that. There's athletes who have pressure lower than that all the time. So it's not a problem unless you start becoming symptomatic. So they don't really worry about that. If you get up and you're dizzy all the time, that's a problem. But most of the time, especially in athletes, don't worry about that. But that is the official number. Okay, if you really have super low pressure, like 75/40, I mean, you can start damaging organs and things like that. So that's a problem. What are the causes of hypotension? Well, man-made. Some of them medications like beta blockers, or maybe grandma and grandpa, they don't have that little pill case and they forget, did I take my beta blocker? I can't remember. And they take like 3 or 4 doses above normal. And that can cause hypotension. Calcium channel blockers, diuretics. Arrhythmias can cause hypotension. PVCs in particular, that affects the ejection fraction if you have a high burden of PVCs. Valvular disease, both aortic stenosis and regurgitation. If you got stenosis, you can't get blood out of the chute into the ascending aorta. Heart failure, the same thing. Blood loss, if you have hypovolemia. Cardiac tamponade, right? The heart is being squished. It can't eject blood enough. Trouble is it can't fill. That's a diastolic problem. Cardiac tamponade. We'll start talking about heart next week. Decreased sympathetic outflow, dehydration, Addison's disease, diabetes insipidus. They can all cause hypotension. Back to hypertension, usually asymptomatic, right? It's the ninja, silent killer. It could start causing some symptoms like headaches, presyncope. I don't think that's wrong. That's from hypotension. Sorry about that. That needs to be fixed. 7:30 out. Some signs of hypertension are headaches, right? You could get blurred vision if it's starting to affect your eyes and things like that. Arterial blood pressure, it rises during, we know this, ventricular systole from left ventricle, mainly left ventricle contracting. It falls during ventricular diastole. We've talked numerous times about the elasticity of the big pipes and how even during diastole, blood keeps moving forward because of that elasticity of the ascending aorta and aortic arch. It also helps close the valves, right, because you get a backwash during diastole. Ideally, what's the blood pressure? It should be around 120 millimeters of mercury. Diastole should be around 80 millimeters of mercury. Hypertension, anything greater than 140/90, unless you go to malignant hypertension, but that's still a form of hypertension. So hypertension is anything over or at 140/90. If you hit those numbers, you have hypertension. But remember in lab, we talked about white coat hypertension, how common that is for people to get nervous, have hypertension at the doctor's office and not at home. Hypotension is less, we said that already, anything less than 90 or less than 60. Hypertension, 4 key factors, or blood pressure in general is kind of controlled by 4 key factors. More physiology here. Stroke volume or cardiac output. The greater the cardiac output or greater the glob of blood coming out of the heart, the higher pressure you have. Then the distensibility of the artery tree that receives that pressure blast. Normally you stretch out when that pressure blast hits your ascending aorta, and that dissipates. It kind of takes away some of the force and some of the pressure because it absorbs it, kind of cushions the blow, so to speak. As walls stiffen, you get a we'll see in a little while, you get a increase in systolic pressure because of that. Get systolic hypertension. Peripheral vascular resistance, so how big the lumen is. If you get a beaver dam from, let's say, PAD or atherosclerotic plaquing of the abdominal aorta, that's going to increase blood pressure as well because you have to push through that beaver dam. Blood volume, if you get too much, if you have hyperaldosteronism, you have too much blood, too much salt and water in your blood, you will get increased blood pressure from that. That's another way to do it. Blood pressure maintenance, the body maintains blood pressure by adjusting those factors. Cardiac output is adjusted. If you have hypotension, you crank up the cardiac output. Push more blood out instead. That's not good though, right? Because it'll wear out the heart over time, cause left ventricular hypertrophy, congestive heart failure. You can also adjust the peripheral resistance as another way. Example of a patient with a failing heart, they have chronically decreased cardiac output. So they initially would have hypotension, but they don't. In fact, they have a little hypertension, usually on the little hypertensive side. Why? Because the R2A system is constantly turned on to fix that problem. So we get back to a more normal pressure, which tends to be on the high side. But we said there's some negative sequelae of that, right? What's the negative sequelae of that, having the R2A system on all the time? Who's the negative dudes? Angiotensin 2, aldosterone. Why are they negative? They wreck the heart, right? Remember, they stimulate gene transcription of certain growth factors, and that thickens up the heart and makes it inflexible, and it doesn't beat well, and that has to be addressed. The Paul-Zuli's law, remember this thing? We're not going to do this. I used to go into this, but you guys had enough of that. Interesting, though, easy board questions. Always, maybe not you memorize the equation, but always know the relationships. You don't have to know to do formulas, but you have to know what happens to blood flow if you increase the length of a blood vessel. So it's inversely related. So it would, if the length increases, the blood flow would decrease. Remember that? What happens if you increase the radius? Because it's on the top part of the equation, it would be the same thing. So if you increase radius, then you increase blood flow. So you should know how to do that. Not for me, it's pretty rare to put one of those, but you never know what I'll do. I never know what I'm going to do until I start writing the test. What are the major risk factors for hypertension? Atherosclerosis is a big one. We've talked all about that. Renal failure, failing kidneys which can't kick. Normally your Bowman's capsule that dumps sodium into the filtrate. Normally most of that sodium is returned immediately through the proximal convoluted tubules, but people with kidney failure, some types of kidney failure, you can't even kick sodium out of your blood. And therefore, too much sodium, you have too much water, therefore you have hypertension because of that. And let's see. And then to make it worse, if you have hypertension, the arterioles go into vasoconstriction. To protect the capillaries, have to have just the amount of pressure, so that arterial constant constriction will cause even a worsening of the hypertension. Chicken or the egg. So either one of these conditions can spark the other. Hypertension puts more strain on the endothelial lining, allows more LDLs to sneak in. LDLs spark the atherosclerosis, which causes a beaver dam. Right? Atherosclerosis causes a beaver dam, and that increases hypertension. And the increased hypertension causes more LDLs to sneak in. Right? And that causes worse beaver dam, and you get this vicious cycle between the increased hypertension, increased blood pressure, and worsening of the atherosclerosis, plaquing. Vicious cycle. It's the silent killer. There's the hypertension ninja. Talked about that already. It's because you won't have any symptoms, and your first symptoms may be angina, going up the stairs, or maybe you have a TIA. It could be the first symptom. Hope for people who never go to doctors. You got to get that blood pressure. You got to once a year, you got to see somebody and get a physical, especially older people. A third of all adults, Americans, have chronically elevated blood pressure. That's 33%. That's insane, right? That's not Marfan syndrome, 0.01. That's 33% of Americans have hypertension, and they're supposed to be on meds. Many of them aren't on meds. So it's a huge problem. It's a huge killer. There is, what about the natural history of hypertension? This famous, and there's been subsequent studies. This is an older study. But the old Farmington Heart study, I think you guys have actually heard about that, showed a couple things. Systolic pressure tends to slowly increase with the passage of time. It even starts in adolescence, and it increases slowly until the day you die. Diastolic pressure is a little bit weird. It increases also with age up until your 50s. Then it can actually start going backwards. We're not 100% sure we understand why. Something to do with weakening, decreased ejection fraction is possibly thought. All right, should we go down here? Let's do isolated systole. So you can have a systolic hypertension only. So that occurs when systole is at or greater than 140 and diastole is still under 90. That's isolated systolic hypertension. This is the most common form of hypertension in people over 55, especially in females over 55. They have to be watched. It's almost better to have systolic and diastolic hypertension than this one, because there is studies on this that shows they have a higher chance of having heart failure. So they should be on meds to lower that pressure. Isolated systolic hypertension, the pathogenicity, it is, what causes it? Did I miss one? I missed a huge one, didn't I? Did I miss one? Where's the... Oh, there it is. I was going to say, yeah, because the surprise one here is it's seen in the older group, but it's also the one that's seen in young adults, right? This young and old adults are affected by this isolated systolic hypertension, especially male athletes. There's some studies that show male endurance athletes, like cross-country runners, up to 25% of them have systolic hypertension. And it doesn't affect young women. I've always asked this question. It's a good one to know. It doesn't usually affect the women athletes, but it's the male. And it doesn't have to be an athlete, but it's often male athletes. So old people and young people are affected by that. All right? Pathogenicity, so in older people, it's thought to occur secondary to arterial sclerosis, usually atherosclerosis and Monkberg's, maybe even arterial sclerosis is involved as well. But it's basically a hardening of the arteries. And if especially the ascending aorta and aortic arch, if they've lost the ability to stretch and absorb that big blast of blood that's coming out of the left ventricle, if they're hard as a rock, that force is going to be transferred right through the arterial tree, and that's going to result in hypertension during systole, more so than diastole. So stronger than normal pulse wave is sent through the system. Okay, who are at risk? We just said older adults here. But younger adults are also at risk, as we said. We just said male athletes. So what's the deal with these young athletes? Why are they getting isolated systolic hypertension? We're not 100% sure, but the research shows that they do tend to have overactive sympathetic systems. They have too much sympathetic tone. Too much sympathetic tone means too much of the tiger's getting out of the vasomotor center for whatever reason. Maybe there's a problem with the nerve of hearing not being able to fire enough. Who knows what it is? We don't know for sure. They also tend to have, especially the athletes, have a very strong and powerful heart. So you combine that with extra sympathetic tone, so a stiff aorta, you're going to have elevated systolic pressure. Okay, I think we're going to cut it off right there. I think you've had this already, and this is going to mark the end. I'll just say there are two types of hypertension, so secondary and primary. 95% of people on the planet, that huge chunk of people who have hypertension, 95% of them, they don't know what the cause is. That number would drop if they really dug in and looked a little deeper for the cause. Only 5% have secondary hypertension. Secondary hypertension means the cause is known. I said I was going to stop, but I mean, this is important. I think we've actually talked a lot about this. Atherosclerosis. Yeah, let's cut it right there. All right, we'll cut it there. Just wanted to at that slide. All right, see you in the next video.